Welcome to you. Welcome to you too. I hope you guys are going to do well in year two, inshallah. Let's talk about cellular adaptation. Then we're going to be talking about cell injury and cell death. And then towards the end of the block, inshallah, I will be giving you the neoplasia. Okay?
If you don't mind, could you
Speak up.
Yeah.
Do you have any microphone?
Yes.
You have this microphone, right? This? Yes. Why do they give you this feels like a rock star. You know what I'm saying? Always actually the boys, they give them with the cellular adaptation. What happened? If you don't get my jokes, it's okay. I think you will need a little bit of time. What do you see here? The cell usually is faces a lot of challenges, during its lifetime. So one of the things that it faces is actually, stress of any sort. Whether it is in the form of hypoxia, it is in the form of compression from a nearby tissue, it is in the form of mechanical trauma, in the form of actually chemical exposure, any kind of disease state, any kind of stressor that is going to affect the cell. The cell will respond to that in a couple of ways. That's going to depend on the type of injury, the amount of injury, and the duration of the injury the cell is exposed to. Now, there are types of injury that is going to result in simply the cell becoming no more, cell death right away, right off the bat. For example, if the cell is facing chemical exposure, and the reason for that, chemical substance, chemical poison, if you will. The reason for that is that chemical poison will act as, I'm not sure if you have seen it in the year before, preparatory year, or in first year, but this chemical substance either itself will be actually a what you call a free radical, or is going to be metabolized into a free radical. And the free radicals are known to act on two components, to have affinity to two components in the cells. The first component is going to be the cell membrane, and the second one is going to be the nuclear material, the genome of the cell. We need to do it? Yeah. Let's talk about okay. So facing all these these stressors, the cell will respond to this in a couple of ways. If it is a mild stressor, if it is of a special mild type of stressor, that kind of stress or disease state, the end result is going to be that the cell will be able actually to mount what we call an adaptation response. The adaptation response is the mildest, believe it or not, the mildest type of response from the cell to an ongoing injury. Okay? If this process goes on unabated for a long period of time, this mild response, this adaptation will cease to happen. And in its place will come actually cell injury. Why? Because at one point in time, the cell would have used all of its powers in the form of ATP to fight the pressure or the stress or the disease that is happening. And at one point in time, it will simply throw in the towel and say, I quit, right? And that's when the cell injury will happen. Now, cell injury itself is also two types. There is the reversible cell injury, and then there is the irreversible cell injury. And again, depending on the amount of injury, depending on the duration of the injury, and depending on the type of injury, then that's going to decide if the cell is going to go a reversible cell injury versus irreversible cell injury. What's going to decide, if it is reversible or irreversible will be, one of, three things, as we will talk about in the next slide after this. All right, so as long as the cell has the reserves, at its disposal, it will be able actually to deal with the ongoing insult. And by reserves, it means only one thing: ATP. For you, for us, for everybody, it means money, right? You have money, everything is fine, right? You can deal with any kind of problem you have. You don't have money, good luck. So in this case, for the cell, it is ATP. As long as ATP is there in ample amounts, The cell actually could use that ATP to divide, to bring in more, actually, if you will, more cells to take care of the mechanical overload, for example. That's going to be what you call hyperplasia. All right, so this is one. Two, or the cell actually may decide to become a bigger version of itself to be able to take care of this mechanical overload again. That's what you call hypertrophy. Okay, the cell actually at one point in time may be a very what you call introverted cell, and may decide that, you know what, let's say it's a rock. What we are dealing with is it is in the rock of the middle of this room. You try to move this rock, you cannot move it. You bring in your brothers and sisters and friends to move the rock with you. That's hyperplasia, if you think about it. It's a good metaphor, right? Or actually, and you guys know that very well, you go bulk up in the gym for about 3-4 months, right? You become like a bigger version of yourself. You come and move the rock yourself. Okay, that's hypertrophy. Or actually, you may decide, like, why should I bother about the rock? The rock is good. Leave the rock where it is. I'm not going to touch the rock. That's what you call an isolationist kind of attitude, And you may decide actually to go in the corner, you or the person will, go in the corner and will not bother the rock. The rock itself will stop actually seeing it. That's what you call actually, after a while, the rock will forget about him. Everybody will forget about him because he's sitting in a corner. That's what you call atrophy, okay? Withdrawing and getting smaller, than, because you're not working out, you will get smaller eventually. So that's atrophy actually. Or you may decide, what, the rock needs a new personality to deal with. It needs someone who is actually reinventing himself, becoming a new version of himself or herself. That's what you call metaplasia. Okay? That's, for example, the rock is probably a bad example when it comes to that. So let's say that, let me give you another better example, medical example in this case, not a social example. Let's say that someone is smoking. Okay? The first thing that the bronchial epithelium is going to respond to is going to be in the form of actually hyperplasia and hypertrophy. The cell will simply divide because they have the ability to divide, and then they will become a bigger version than themselves to be able to withstand this actually incoming insult of toxins that the patient is bringing into his airway, right? So that's number one. After a while, after a period of time, of a lot of infections, a lot of inflammation in the form of chronic bronchitis, possible emphysema as well. The result of that will be what? The bronchial epithelium itself will say that is not really working. There should be a better way of dealing with this. It cannot atrophy because that will not solve the problem. So actually there will be a switch at the level of the basal cell layer, a genetic switch at the level of the stem cell layer that is going to turn actually this epithelium from a columnar epithelium into a squamous epithelium. That's what you call a metaplastic process. So in this case, the tissue simply switched into a different type of tissue. Why? Because the squamous epithelium is more able to withstand the amount of toxins that this patient is breathing in and out every time he smokes. Okay? So that's what you call reinventing, the cell, really, redoing the cell. Going back to the genome and starting from scratch into a new, different, line of cells. These are the 4 adaptive, responses that you will see as a result to cell injury. And they will happen as long as the cell reserve is intact, as long as ATP is being made in ample amounts. All right, so here's the cell that is facing an injury or a stress. That's going to be actually, first response is going to be in the form of adaptation. If, again, the duration is short. 2, if the amount of injury is small. And 3, if it is not of a specific type that will result in cell injury rather than cell adaptation. We'll talk about that in a second. So as long as these 3 conditions are met, then you are actually at the adaptation stage. If the adaptation goes on because the stress is ongoing, even though it is at the first stage of adaptation, and the stress is ongoing, it does not stop, then this adaptation at one point in time, as a result of the depletion of the cell reserves, will move into the next phase, which is cell injury. Cell injury itself is going to be divided into 2 types, depending on the amount of injury that happened to the cell. If the injury that happened to the cell as a result of this ongoing stress is limited to the cytoplasm, that's going to be what you call reversible injury. It is limited to the cytoplasm and sparing the nucleus. Okay? That's what you call a reversible cell injury. When it is actually going into the genome, that's when you start to see the irreversible cell injury. So what decides if the cell is going to actually be in reversible injury or irreversible injury? It is three factors. Is it reversible versus irreversible? You will see that there are three determining factors. The first one is going to be injury to the genome. The second one is going to be injury to the mitochondria. And the third one is going to be injury to the cell membranes. Okay? Now, why do you think cell injury or injury to the cell membrane will result in the cell moving from reversible into irreversible injury? Could you think about a reason? The contents will be spilled out, and that's when actually you will see that there will be a tissue response in the form of inflammatory cells that will come and simply, liquidate everything. Go ahead.
Membrane potentials will be disrupted.
Membrane potential, I would worry more about actually the disruption of the membrane rather than a membrane potential. But wait, no, actually, I take that back. Membrane potential at the level of what? Mitochondria. At the level of the mitochondria. Why is that? You guys know? Why the membrane potential and the porosity of the mitochondrial membrane is so important actually for the survival of the cell?
ATP. Cytochromes.
Because of the production of ATP. Where is the production of ATP happening?
Matrix.
On which, like what part of the mitochondria?
In matrix.
On the inner surface of the mitochondrial membrane. When the action potential is disrupted, that will result actually in disruption of this, electron, transport that is happening on the inner surface of the mitochondrial membrane, resulting of disruption of the oxidative phosphorylation. Why would you care about, even if there is disruption of the oxidative phosphorylation? There are two results of this. One of them is what? Reactive species, absolutely, excellent. Reactive species. So what's going to happen is that because of the fact that the O2 is no longer actually carried all the way to the production of the H2O, right? It is actually, getting, stuck halfway. That will result in a partial reduction of the molecular oxygen. That will result in the production of free radicals, the reactive species that you mentioned. And what do the free radicals like to do? They like to actually, combine. What do they do actually? What do they do? What is the free radical to start with? Why do you call it a free radical? Is it because it's a leftist? No, it's not. Yeah.
It has an extra electron.
It's missing one of the electrons. And what is the tendency of the free radical? Is to steal an electron from somewhere else, from anything else, right? Where does it do that in the cell? Where are the two favorite areas in the cell where it wants? The membrane is one. The second one is the genomic material. It goes after the most two important parts of the cell, and the result of that will be, again, irreversible cell injury. Okay? So, free radicals, you got it. The second one is no longer producing ATP, right? So cell reserves are out, then it cannot really do any adaptation. It cannot divide, it cannot hypertrophy, it cannot, become metaplastic, and it cannot, become atrophic. Okay? Someone was raising his hand, I think, somewhere. All right, everything is understood. That's good. All right, so three things. Now, that's actually with regard to membranes. Why do you think, genome injury is going to result in irreversible injury?
Because you lost the ability to divide and also protein synthesis.
You lose the ability of everything, right?
Yeah.
The genome is the brain of the cell, right? You kill the brain dead, right? Brain dead cell will not function. It will actually cease to happen. So what you call a phenotypic changes, that is the cytoplasmic injury, the reversible injury, the cell may actually, go on at least for a while. In theory, it could actually be recovered. But as long as there is an ongoing insult, ongoing stress, this reversible cell injury eventually is going to actually go the other way into irreversible cell injury and cell death. Now, so we have talked about mitochondrial injury. How about the other membranes? Why would you worry about, why would a membranous injury move a cell from a reversible stage into an irreversible stage.
It's like a nuclear membrane.
Well, nuclear membrane. Nuclear membrane is gone, the nucleus is gone, right? Anything else that will be? Lysosomal membrane. What will happen when the lysosomal membranes are disrupted? Enzymes will be free. They will start to eat up everything, right? You know, in the cell, you know, breaking down the cell, you know, pretty much wholesale, what you call necrotic type of death. Now, you know, is there anything else actually that happened with the how about, you know, the cell membrane itself? The cell membrane itself is no longer, I think we mentioned that.
The balance will be destroyed.
Cell membrane itself is out. The result, you know, the cell contents are now in the ECM, and the, you know, the tissue is going to respond by mounting an immune response, what you call a tissue response, that will bring in the inflammatory cells, simply destroying all these cells, you know, in one piece. Now, the following stage of irreversible cell injury, it's a one-way street that will result eventually in cell death. So with cell death, you have actually two things. You have, you know, an organized form of cell death, you know, what you call apoptosis versus necrosis. Now, you know, I'll give you an example of each. So, for example, you know, when it comes to necrosis, how about if there is a bacterial infection? You know, the bacterial infection, believe it or not, a lot of times will not result in the cell death itself, because maybe the bacteria lacks, you know, some of these very powerful enzymes that will degrade the tissue. What will kill, you know, the tissue, you know, that where the infection is happening?
Maybe the toxins they produce as waste material?
Not usually those, you know, the bacterial cells, but the
white blood cells from
the inflammatory cells. The inflammatory cells that will be brought to the site of infection. In this case, those inflammatory cells are, you know, have two kinds of killing, right? How do they kill? There's, you know, what we call oxygen-dependent, you know, mechanism and oxygen-independent mechanism. What's the oxygen-dependent mechanism?
They use reactive oxygen.
The free radicals, absolutely. So it is the only cell in the body that uses free radical as a matter of policy, as a matter of function, to kill the bacteria, right? So, you know, you bring it in, and these cells are going to be releasing all this good stuff into the tissue. What will happen to the tissue? It will die wholesale, right? That's what you call actually a necrotic kind of death. You know, it may happen from the outside, it may happen from the inside as well, okay? Let's say that, you know, as I mentioned to you, you know, that there is a, in this case, an internal rather than an external injury that resulted in disruption of the lysosomal membranes, releasing all these enzymes that will disrupt, you know, the cell wholesale, right? And it will release its content. The inflammatory cells will come and will destroy the rest. That's what you call necrosis. In a way, actually, this is what you call like a wholesale kind of death, right? You know, like in the same hurricane, you know, that struck Japan about, you know, 4 days ago. When it struck Japan, I think 3 people died. If it struck a third world country, probably around 3 million would have died. You know? So that's what the difference between apoptosis and necrosis in a way. You know, like I guess my way of, you know, calling it, you know, a very organized way to die. You know, in the West, they call the funeral home. You will tell him, you know, like, I will die on this day. You know, prepare my coffin for me on this day. You know, and then there will he will even, believe it or not, they will even set their memorial service. You know, how about this for like organization? Whereas in the third world, you know, we don't really do that, do we? You know, I can talk about the third world because I'm from the third world. So in a way, actually, this is bad for the third world because it gives me the, you know, that's what you call apoptosis, and very organized. So what happened with apoptosis? Apoptosis, on the other hand, is like, you know, again, another form of infection. In this case, it will be a viral infection, for example, hepatitis. In this case, actually, you will see that instead of the cell opening up to its content, to the ECM, and inciting the immune response, you know, practically initiating the immune response, the cell itself will start to dismantle itself from within, because this process, you know, is actually far more controlled. Both of them are genetically controlled, but this is far more controlled than the necrotic process. In this case, you know, both of them are enzymatic, you know, processes that are controlled by genes at one point in time. You know, everything goes back to the genome, right? But this one is initiated from the cell itself as a result of messages that are coming from within the cell or from without. In this case, it is coming as a result of a viral infection. So it's happening from out of the cell, that, from a viral infection that becomes actually part of the cell that is going to, activate the apoptotic, processes within the cell that is going to make the cell get dismantled one piece at a time. You will see that the cell is going to turn into small vesicles carrying a flag on their head, a tag on their head that is going to be recognized by the macrophages. That will be brought to the site, and the macrophage will take in this vesicle in one piece, what we call apoptotic bodies. It will take it in one piece without anything spilling out into the ECM, resulting in complete dissolution, complete, absence of that cell, which is exactly what pathologists use as a pathologic term to describe apoptosis in tissue when they see it. They call it cellular dropout, because they see that there is a dropout, there is a missing cell, in this process. Did you guys get that? Okay. Now, this is a general lecture, so it will be probably harder than the rest of the lectures. As we become more, as we go through this series, inshallah, you will see that it will become easier and easier. So bear with me if you feel that it's a lot of information. I don't need to explain this slide to you. You know it all by now, right? You know it far than any other student, and probably in medicine nowadays. Adapt or die. You have figured it out yourself. Congratulations. All right. So we did talk about this. Now, here's this graph that speaks a lot actually. So again, adaptation and ongoing injury, too much or of a different type or too long, that's going to move the cell from adaptation into reversible cell injury. Does that mean that it has to go through the stage? Absolutely not. The cell could go from homeostasis, phase into irreversible cell injury and cell death right away, depending on the type of injury that's happening. If it is an injury that is focusing again on the membranes or on the genome or on the mitochondria, it will bypass everything and actually go on into cell death right off the bat without having to go through those three phases. So this is what you call academic kind of, a division of those, processes of cell injury eventually resulting in cell death. Now, what is going to decide if the cell is going to go through the point of no return into irreversible cell injury are the three factors that I mentioned to you: genome injury, mitochondrial injury, and membranous injury. Once that happens, the cell actually is on its way, one-way street. There is no going back. There is no recovery of the genome, or of that of the mitochondria, or of that of the disrupted membranes. So we talked about the type of injury. Let's say that actually what's happening is simply an acid that is getting refluxed, or that's going back into the lower esophagus. That is going to result in this, what we call heartburn that you hear about, right? So the first stage, what's going to happen is for the cells in the lower esophagus is that they will start to divide. They will start to make more of their own. That's going to result in what you call acanthosis, actually, of the squamous, of the squamous cell layer of the lower esophagus. So the epithelium will become thicker than it is, trying to actually deal with the incoming acid. Now, what's going to happen if this goes on for a while? After a while, even the squamous epithelium will not be able to, even this thickened squamous epithelium will not be able to take it. That's actually when the cell itself will decide that the best way to deal with it is not really a squamous epithelium to deal with acid, but a glandular epithelium, because it takes example from where? From the stomach, exactly. It takes example from the stomach. Of course, in the stomach, there are other actually features to protect the mucosa than the glandular epithelium. There are the mucosal cell layer, the vascular network that will be able to reroute all this acid that actually seeping through it to somewhere else. So, but still, it's a glandular epithelium. It's better than squamous. So that's when you see a switch at the level of So even actually, we went through adaptive mechanism as a result of this, response in the lower esophagus. So physiologic, I want to add here another word, or actually pathologic stimulus. Okay, either or. If it is of a special type, it will not result in cell injury. Rather, it will result in cell adaptation. On the other hand, if you have less O2, hypoxia of some sort, or chemical exposure, such as what we talked about, chemical poison, or a viral infection, or a bacterial infection, bring in all these inflammatory cells. The result of that is going to be, in this case, it will result actually in cell injury because of the type of the injury rather than the amount or the duration of the injury. So this is what you call a determining factor. Regardless of how much you have, let's say that the cell has faced, arsenic, for example. There is no recovery from that. Okay, if that cell has faced arsenic, the cell will die. Why? Because the arsenic will have worked actually on the genome and on the membranes, resulting in actually disruption of the cell, in a one-way street. And the rest is that as well. So what is meant by the type of injury will decide actually where the cell will be going, one way or the other. All right. So starting with cellular adaptation, what do we have here? By now you know, right? So either you bring in your friends and buddies to actually carry this rock, or you go to the gym yourself and bulk up and you are able actually to carry this rock. Or you decide, what, let's leave this rock alone and go into the corner, right? What you call an isolationist kind of policy or mood, if you will. That's a joke. That is going to result in what's known actually as atrophy, right? The cell will downsize, right? Have you seen that? Countries do this as well. Let's talk about companies. Companies, when they are facing financial hardship, they start to let employees go, right? They start to let facilities go. They cut down on their, if it's an airline, for example, they cut down on their service. So they become a smaller version of than themselves. Why? Because that's going to actually, meet the incoming, financial, what do you call it, the finances that are coming into the company, as opposed to where it was actually growing and expanding. And that will actually help the company, stay in for a while. That's exactly what the cell do, because of the fact that you have meager amount of blood supply, or for example, if there is a little space for that cell, the cell is compressed by a nearby duct, for example, or nearby tissue that is growing. The result of that is going to be that the cell will decide, let's become a smaller version of myself and see where that takes me. Usually it will survive for a while. Now metaplasia, if everything else fails, and then the cell will decide to simply switch sides or switch, personality in this case, reinvent itself into a different, type of cell that is more able to withstand, to take in, the pressure that is happening. Now dysplasia, why do you see, everything here as a solid block line and dysplasia as an interrupted block line? Why? Because because of the fact that actually a lot of pathologists and scientists feel that dysplasia is more of a cell injury response rather than a cellular adaptation. And their reasoning is that dysplasia is a one-way street. Once the cell becomes dysplastic or quote unquote transformed, then there is no going back. Now there is the small minority in this, usually the academician, who live in their own bubble, they are not in the real world, who will come to the heroes, to the practicing pathologists and tell them, but we have an example actually to show you that actually dysplasia could be reversible. Could you give me an example of a tumor that you could reverse with antibiotic? That's a good example to be actually said when it comes to the discussion of dysplasia. Is it a adaptation or is it actually a cell injury? Do you have any example of a tumor in the stomach? The tumor happens in the stomach. Any of that? No. If you actually reverse that, you will get a new surprising medicine. Is there anything else that is not a universal? What else happens in the stomach other than carcinoma? Anything can happen in the stomach, right? Huh? What causes peptic ulcer?
H. pylori infection.
H. pylori. What does H. pylori also cause? We're getting in this POD. What does H. pylori cause? It can cause cancer. What type of cancer? What type of tumor? Malignant tumors. Okay. How about if it causes actually a special form of lymphoma known as maltoma? Have you guys heard of it? Because associated lymphoid tissue tumors. Okay, maltoma. And that's actually the other name for it is marginal B-zone lymphoma. Marginal B-zone lymphoma, resulting from H. pylori infection. There's a subset that results from H. pylori infection, How about this? Listen to this crazy statement. Could be reversed with antibiotic therapy if it is in the early stages of the treatment. As crazy as that may sound, please check it out for yourself and you will see that this is correct. Okay? So, they give you this example to tell you that actually dysplasia and cancer is reversible. Okay? But you see what I'm saying? Academician is a lot more about or academia is a lot more about give and maybe not take. Go ahead.
Do these adaptations happen in order always, or they?
No, absolutely not. The cell may go actually into metaplasia, right off the bat, depending on the kind of injury that is going on. But usually, more than less, it will go through, this actually phases. Not, for example, let's say that actually you are within the bladder, and the person, got a schistosomal hematobium infection, bilharzia infection. So as a result of that infection, you will see that the eggs of the parasite are going to get embedded in the lamina propria of the mucosa of the wall of the bladder. That will result in chronic inflammation because inflammatory cells will be brought to that site. What will happen to the overlying epithelium? First, it's going actually to start to become larger, bigger, hypertrophic. And then it will realize that this is no longer happening. It will start also to divide as well, because it can divide. So hyperplastic. And then eventually, when everything fails, it will switch from the transitional epithelium or the urothelial epithelium into what is known as a squamous epithelium. Okay? So most of the time, that's a good point. Most of the time it will go like this, but it does not need to. It may actually simply opt for the metaplastic response right of the back. Now to show you actually the same example. So once the squamous metaplasia sets in, if this goes on for a while, then actually squamous cell carcinoma may happen. But in that case, there is no reverse. So how would you call, as an example of what the majority of pathologists and scientists will say, how do you call dysplastic or dysplasia reversible? Because you're not able to reverse actually the cancer that is arising from a squamous metaplasia. Did you guys get that? You don't need to know that. You don't need to worry about it. I promise you that I will hammer it in your head. By the time you finish, you will be probably teaching this material. How about that? Okay, so again, it is a continuum, if you will, including dysplasia. But the dysplasia, why do you call it adaptation? Believe it or not, you're calling it adaptation because there is a way back. Okay? It may go back to normal. If it has gone into injury, then all bets are that this cell is going to go into cell death eventually. It may go back from reversible cell injury, but that's really a long shot. For the majority of those, the cell is adapting to the new state, but it is going back. The fact that dysplasia in the 99% of the time, barring actually this example that I mentioned of maltoma in the stomach, then with this case, you would have to call dysplasia a one-way street, and that's why you would call it a cell injury response rather than a cell adaptation response. Okay? The cell is no longer adapting to the new state, rather actually the cell is simply coming up with its own disease entity, which in this case is going to be cancer. All right, we will meet that again when we do to the discussion of cancer at the end of this series, inshallah. Okay? Is everything understood?
Can a cell go hyperplasia and hypertrophy at the same time?
Yes, absolutely. Actually, a lot of times they go under. So the cell will become hyperplastic and hyper. And be what? So order? Disorder. Well, metaplasia is a. What do you mean by disorder? No, it cannot. Metaplasia is an intermediary phase. It may go back to normal. So squamous metaplasia that happens, for example, as a result of HPV infection in the cervix, you treat the HPV infection, or the HPV infection is no longer there, the cell may go back. So it is not a one-way street. There is a way back. The same with smoking. You stop the smoking, the cell may actually go back to the columnar cells. Okay? So you leave the insult, you remove the insult, and the cell will go back to normal. All right, so tell me what's happening in this poor guy, 87-year-old with a complaint of difficulty in starting urinary stream. What happened to this guy? 87 years old. What could actually result? Anything can happen, right? As you grow up in age, anything can happen. You know, age is probably the worst risk factor that anybody will deal with. Okay, but what's happening specifically in this person?
Prostate.
Prostate. So what's happening in the prostate? Hyperplasia. Okay, very good. And what is this hyperplasia doing? Compressing the urinary stream. So now, you know, what part of the prostate is this happening in? Transitional zone. So it is the area that surrounds what? The urethra, right? What do you call that urethra? Prostatic urethra. Okay. So when this guy, let's put that in clinical. When this guy is starting actually to urinate, what will happen?
He will face
So there is failure of initiation of urination, right? So he will fail to start the urinary process, the urination process. And then when he urinates, what will happen? It will keep on closing onto, you know, this prostatic urethra. So you will see interruption that will result in what's known as dribbling. Okay? So one of the things that you see in those patients is that they stay for a good period of time. This is how you know if he has, you know, they go into the toilet and they will stay, like, instead of 2 minutes, they will stay 10 minutes because they are actually waiting to start the initiation. Now, what does that actually cause for the urine that should be voided? What happens to it? It will build up where?
In the bladder.
In the bladder. Okay, so what is that going to result in? UTI, exactly, in the form of cystitis, right? Okay, cystitis, so lower UTI, that may actually be going into higher UTI, right? Cystitis, there's always a chance that it may actually go back, a good chance actually that it may result in an upper urinary in the form of, you know, pyelonephritis, right? And that's going to result in what after that? Into the blood, right? That result in sepsis. That's exactly what this guy suffered from. Eventually resulting in a septic shock, right? And death. So the underlying cause of death in this case is gram-negative sepsis. Remember this rule: if there is stasis anywhere in the body, it doesn't matter really with what. What is the, you know, the fluid that is accumulating? That's a risk factor for infection, regardless of where you are. All right. So what do you see? You do autopsy to figure out what's happening. And this is the prostate. The prostate normally is about, you know, 2.5 by 2 by 2, a pyramidal kind of organ that is really pretty small, you know, when it is in normal state. And this one, it's at least probably in every direction, it's going to be around 10 to 15 centimeters. So it's like the size of a ball. And, you know, you can imagine the difficulty that this poor guy was having, you know, when the urinary stream was passing through the prostatic urethra. You know, you can see, in addition to the fact that the size is bigger, you see on the cut surface the presence of these white nodules, right? And these white nodules are actually what you call the prostatic hyperplasia. Now, you take that back, you know, again, you know what, the best thing in pathology is to always bring in the normal and compare it to the abnormal, okay? Whatever it is, really, if you have a problem, usually it is not, the problem is not in pathology, it is in histology. Go and bring in the histology, the normal histology, and compare it to what's happening in the pathologic process, and you will see that it becomes much easier. So this is a section of a normal prostate. This section of a normal prostate shows a smaller section. This is 1, 2, less interstitium, 3, less glands, and the glands are not really that wide open, as opposed to here in a hyperplastic, you know, prostate, similar to the one that we have just seen, where you see a lot of interstitial space and a lot of glandular tissue as well. So both elements, the interstitial element and also the stromal element, as well as the glandular elements, are hyperplastic in this patient. And here, when you take a section, when you go in higher power, you will start to see that these cells, you know, instead of having 1 to 2 only of cell layers that will line this fronts, prostatic fronts, you will start to see that there is accumulation, piling up of these cells on top of each other in a process known as stratification. Okay, so they will become, you know, there will be a lot of stratified kind of, you know, and piling up, you know, of cells on top of each other. Now, you know that this is still a benign process. Why? Because if you look at these cells, all these cells look the same. This is one. Two, if you look at the amount of cytoplasm, it's a lot of cytoplasm. So where does that leave you with the NC ratio, the nuclear cytoplasmic ratio? So nuclear cytoplasmic ratio is normal, which is actually low, right? So because the nuclear size is small and the cytoplasmic size is ample, is a lot, and as a result of that, the NC ratio will be actually low. So you're still dealing, this is one. The other one actually, if you look, do you see this basement membrane of this papilla right here? Is it invaded with any of these cells?
No.
No. So that's the lack of invasion of the basal cell layer, not only of the fronts, but also surrounding the glands from the outside. You can see a very important basal cell layer. It was really the only thing that pathologists rely on for almost like 100 years of prostatic pathology until the late 1990s and early 2000. It was simply the presence or absence of this basal cell layer, that will tell the pathologist if the patient has prostatic adenocarcinoma or not. Now we have actually new tools at our disposal that will stain the malignant cells and will not stain the benign cells. So we are a little bit more advanced in this process now. All right, so hyperplasia, that's going to result in the increased size of the organ, that increased size, increased weight of the organ. Another way actually for you to measure hyperplasia is the weight of the organ, especially when it comes to endocrine, hyperplastic tumors, endocrine or hyperplastic conditions. Let's leave it at this. All right, now, what decides if that tissue is going to become hyperplastic or hypertrophic? What's going to decide is the type of tissue itself. Is it a tissue that could divide, or is it a tissue that never divides, right? Could you give me an example of tissue that never divides?
muscles.
In reality, even those tissue divides, but their division is so slow, it will take a lifetime for the neuron to grow, for example. Okay? So theory versus practice. In theory, they could do this, but in practical sense, it will make no use whatsoever. On the other hand, there is tissue that actually divides and divides and divides. What is that? GI, for example. Skin is another example. So in this case, you see what we call labile tissue that will actually divide and inhibit it. And then there is a special, what you call it, a special, tissue that is in between labile versus, permanent, what you call a stable tissue that will divide only when there is injury. What? Give me an example of that. Liver, for example, is a good example of that as well. All right. So the type of hyperplasia that we talk about, including physiologic hyperplasia, such as what you see in breast, in lactation, what you see in the endometrial hyperplasia, following, at least endometrial growth, should say, following menstruation. And then there is the pathologic hyperplasia that is seen in a lot of entities. So starting with, the physiologic hyperplasia in lactation, that's a clear example of the effect of the hormones on the breast tissue, where you will see that it's going to prepare itself for the lactation, act, if you will. Now, concentric hyperplasia, you take out about 7/8 of the liver, you leave 1/8 of the liver, and that liver is going to grow. If you take it out in the form of surgery, that liver is going to grow to almost its normal size after a while. And that actually will happen as soon as 12 hours after the removal of that tissue. Now, how does that happen? When an epithelial, benign epithelial cells becomes contacted by other epithelial cells from all sides, it will cease division. Okay? When it loses this contact, that's actually when you see division will start to happen again. And division will happen in those cells that have lost contact as a result of the loss of tissue, as a result of the elaboration of polypeptide growth factors from the uninjured hepatic cells. Okay? So that's when those cells will start to divide and give rise to the lost tissue. Now, how does that cease to happen? This is amazing because this is the almighty plan as opposed to, for example, the stem cell plan that man is trying to master. What happened with stem cell, it's a great idea, right? You give stem cell to a tissue that is suffering, tissue loss, and the hope that it will actually grow. It will grow absolutely, but you cannot control its growth. This is really where the trick is happening. Boss, how you doing? You're done? Am I done?
Yeah. Almost.
So the opposite. So with regard to stem cell, that's not going to happen. with stem cell, or at least they are trying to master it, it's still an iffy answer. Whereas here, simply when this growth happened again, and this cell, had contact from all sides again, it will cease to divide. And that's exactly what you call, what you call that process. Anoikis. A-N-O-I-K-I-S. All right? All right, guys, we'll continue. This lecture was what we call a general lecture. Okay? And you will see that the rest of